So the class 1 sodium channel blockers, as we have already mentioned in our previous lectures, that all the drugs which are anti-arrhythmics, they would like to do one thing, and that is to increase the action potential duration and increase the effective refractory period, so that there is less of conductance and there is less of arrhythmia. Now the first bullet point that we have is it blocks the fast sodium channels. And when I say it blocks the fast sodium channels, I do not necessarily mean that I'm blocking all the sodium ion channels. If I do that, I'll have a flat EKG. That means the patient has already died. What I mean by blocking the fast sodium ion channels is that I would like to block
Zero is
I would like to block enough of the sodium ion channels so that there is decrease in the conductance of sodium. So if a patient is having 250 beats per minute of heart rate, that will decrease down to 120 beats per minute, which is quite normal. So the first bullet point about class 1A drugs is that it blocks the fast sodium ion channels. It preferentially binds it, it blocks the open or inactivated state that we have already discussed. Now, let me show you with the help of a diagram. Imagine this to be a normal cardiac action potential of a fast response fiber. Now, if I put up a class 1A drug at the beginning of the action potential, what I'm doing with the class 1A drug is that I'm acting on the open and active state, right? And this is what I'm doing. So I'm not doing anything to the plateau phase. I'm not doing anything to the repolarization phase. What I have done basically is, if this was your earlier action potential duration, right, till here, now with the help of class 1A drugs, I have acted on the fast sodium channels, which is the phase 0. Fast sodium channels work on the phase 0. And what I did here is that I have increased or lengthened the effective, the action potential duration. And when I increase the action potential duration, what I have done indirectly, I have also increased the effective refractory period. That means it will take longer than usual for this cell to initiate another action potential. So when that happens, in a case of arrhythmia, the 250 beats per minute what the patient was experiencing will now dramatically drop down to 150 beats per minute. So what I have done, I have just lengthened the phase 0. I have started from the same point, but I have blocked the sodium ion channels on the phase 0 and have lengthened the action potential duration and also the effective refractory period. So this is what the class 1A drugs basically do. They increase the action potential duration by acting on the open and the activated state of a voltage gated fast sodium ion channel. Now, the last point before we move on to the drugs is that it also blocks the potassium ion channel. But I'm not going to show it to you on the diagram because it will get complicated. And also that this activity or this property of a sodium channel blocker is not that prominent as to be talking about it also. Otherwise, we wouldn't have had sodium channel blockers, we would have just had potassium channel blockers. So just remember these 3 bullet points about class 1A drugs. They block the fast sodium ion channels. That means they will delay the depolarization, right? And then they will preferentially bind in the open and activated state of a sodium ion channel, and thereby they increase the action potential duration and effective refractory period. And that is what we wanted with respect to the antiarrhythmics. Now let us talk about the drugs. Now the drugs, basically the prototype drug of class 1A is your quinidine. All right. Now the important points with respect to quinidine is your
muscarinic blockade.
these 2 points. The first point is it is a muscarinic receptor blockade. What does it mean? It means that this particular drug, quinidine, will behave like your atropine. Now, from your ANS pharmacology, if you remember, atropine is a drug which is a muscarinic blocker. That means it will increase the heart rate. So now we are talking about a drug, quinidine, which we are saying that it is a class 1 sodium channel blocker, basically an anti-arrhythmic. and we are saying that it also possesses the property of muscarinic receptor blockade, which has a potential to carry on or increase the heart rate. So it is quite of opposite to what we are actually talking about or what we wanted to do, right? So let us look at the second bullet point. It is also an alpha blocker. That means alpha blocker, basically they decrease the blood pressure. So if this drop in blood pressure is big enough and quick enough, you know from your ANS pharmacology that it can elicit a potential reflex tachycardia. So we have an anti-arrhythmic that has the property of muscarinic receptor blockade and also an alpha blocker, both of which are causing an increase in the heart rate, which is quite opposite to, which is quite in contrast to what we were actually trying to do. We're actually trying to decrease the heart rate, and this particular drug is increasing the heart rate. Now, what are we supposed to do? We are supposed to bang our heads on the wall. But the question is, do we still use this drug? Yes, we use this drug, and we use it in many arrhythmias. The fundamental arrhythmia that we use it is in your atrial fibrillations. Now, atrial fibrillations are not deadly per se. They are not as deadly as ventricular fibrillations, which causes
Wavy pulse.
yes, which causes a decrease in your cardiac output or decompensates your cardiac output. But what happens in atrial fibrillation is that this is a little bit of pathology. What happens in atrial fibrillations is that because of the fast beating atrial beat, you can have some amount of stasis in the atrial chambers. Now, there is something called as Virchow's triad, and Virchow's triad tells us that
Yes, sir. Coagulability.
yes, Virchow's triad tells us that stasis, turbulence, they are some of the these are some of the things that will result in hypercoagulability and endothelial injury. Now, when that happens, there is a chance, there is a potential threat of forming a pathological thrombus. All right. Now, this pathological thrombus could get ejected into the systemic circulation, causing infarction in tissues. And if that pathological thrombus reaches your brain, it could result in stroke. So that is the reason why atrial fibrillations are quite dangerous. And that is where your quinidine comes into picture. And the second thing is, what if that fast atrial beat, due to fast atrial beat, now is being transferred to the ventricles through the conductive system of the heart. Now, when that happens, you will be compromising your cardiac output, leading to ventricular fibrillations and potential death of the patient. So you have to treat this atrial fibrillation with the help of quinidine. So how do you treat this particular patient? Now, what you do is you try to slow the AV conductions with the help of quinidine, and you also at the same time try to digitalize the patient. That means what you do is you take quinidine and you along with quinidine you give digoxin. Now, this digoxin it basically causes a decrease in the heart rate, and this you will be talking about in your congestive cardiac failure chapter, more about digoxin. But what you need to remember at this point in time is that digoxin is given along with quinidine to slow the AV conduction in case of atrial fibrillations. Now, one thing that I would like to add about digoxin is that digoxin is also a pro-arrhythmogenic agent. That means it is capable of causing or increasing the heart rate. That is why you need to monitor the patients from time to time. So more about digoxin when we study about congestive cardiac failure. Now, coming to the adverse effects of quinidine, there is a certain term which is referred to as synchronism. Now, synchronism is nothing but a group of symptoms or effects that is seen with quinidine. It includes gastrointestinal disturbances. It includes ocular dysfunctions, CNS excitations, and CNS tinnitus. Now, basically, what I'm trying to tell you is that these synchronic effects of quinidine, they occur because of the muscarinic antagonist activity of quinidine. Now, let us take GI for example. All right. Now, if quinidine possesses muscarinic antagonistic activity, what should it do at the level of your GI system? Should the patient have constipation or diarrhea?
It should be having constipation because it prevents the movements.
Yes, the patient should have constipation. Now, you also know that quinidine is also a alpha receptor blocker.
Vasodilation, reduced peripheral, decrease in BP.
So if it is an alpha receptor blockade, what should it do at the level of your gastrointestinal tract? Should it cause constipation or diarrhea? It should cause diarrhea because it will relax the smooth muscles.
Smooth muscles.
So what is the patient likely to have then? Should the patient have got constipation or should the patient have diarrhea? Because quinidine possesses both the properties of muscarinic blockade as well as alpha receptor blockade. So what we do, we just write the patient will have GI disturbances because the patient is likely to have both constipation as well as diarrhea. Constipation because of muscarinic blockade and diarrhea because of alpha blockade. Okay, now let us take another example about ocular dysfunction. Why did I mention ocular dysfunction? Now, if it is a muscarinic blocker, that means it will cause mydriasis.
Yes.
And if it is an alpha receptor blocker, that means it is likely to cause meiosis. So what should the patient have now? Mydriasis or meiosis? So what we do, we simply write it as ocular dysfunction. Now, quinidine, if it crosses the blood-brain barrier, it also can cause certain CNS excitation. It can cause CNS manifestations like hallucinations and deliriums. So we just simply put it as CNS excitation. Then it also crosses the middle ear and results in certain tinnitus also. So synchronism is a group of symptoms seen with quinidine that is characterized by tinnitus, ocular dysfunction, CNS excitation, and gastrointestinal disturbances. And you also know, since it has got alpha receptor blocking property, it can also cause hypotension. Now, quinidine sounds like quinine. Quinine are basically your anti-malarial drugs, and anti-malarials which are isolated from a bark of a tree that basically grows in South America. It is called as cinchona tree or Cinchona officinalis. Now, that is the reason why the adverse effects of this particular drug are referred to as synchronism, because it is derived from Cinchona officinalis. Now, the one important thing that I would like to add over here, the fundamental adverse effect of this drug is the prolongation of the QRS and the QT interval. That is referred to as toxard. Now, this is one of the most dangerous types of arrhythmias that we can get. Now, just imagine, you have to laugh at yourself that you are basically studying a drug which is classified as an antiarrhythmic, and we have an adverse effect which is the most dangerous type of arrhythmia that this drug can cause. So, what is basically this toxard? It is called as toxard de point.
Normal breakage of heart rhythm.
So, imagine this.
Sudden death.
Yes, imagine this to be your normal ECG with your P wave, QRS complex, and your T wave. Or this is your QRS complex and your T wave. So what happens basically in this type of arrhythmia is that when you speed up your AV nodal conduction, that means you are going to speed up your ventricular depolarization sooner. That means your QRS complex is going to start sooner, and that means your cell will remain in a depolarized state longer. That means this particular T wave of yours is going to come at a later stage. So this particular normal ECG of yours is going to become like this. Now this happens when there is abnormal automaticity in the AV and SA node because of atrial fibrillations. So this normal ECG will now convert into this. There will be broadening of the QRS complex like this, and then your T wave will come at a very later stage. That means your QRS complex will be broadened. There is increase in the length of the QRS complex, and your T wave will come at a later stage. That means your cell will remain in a depolarized state for a very long time. So this particular ECG that I have shown you is just a very just a stop in the camera that I've shown you. But when you monitor a patient having Toxart, his ECG will look like this on the monitor. It will be basically like this. So when this fast beating heart, the nature of the heart goes on, it will eventually lead to ventricular fibrillations, and that will eventually cause the death of the patient. So an anti-arrhythmic drug, quinidine, is capable of causing an arrhythmia, which is called Toxart, and that can lead to death of the patient. But apart from having these adverse effects, we can use it in atrial fibrillations and majority of the other arrhythmias also. So this is one of the drugs, fundamental drugs or prototype drug of class 1A sodium channel blockers. Now, when you're reading about so many adverse effects, you have to keep in mind the drug interactions also. Now, when there is hyperkalemia, it will enhance the effects of this particular drug. That means hyperkalemia, what does it do? It depolarizes the cell further. So it will enhance the activity of these drugs. So you have to make sure that the patient has got normal electrolytes. And then it can also displace digoxin. That means the digoxin will become free. And since I've just now told you that digoxin also possesses the property of pro-arrhythmogenicity. So it can also cause arrhythmias in patients. So you have to keep these two important drug interactions in mind. Hyperkalemia, it depolarizes the cells further, leading to enhancement of the effect of quinidine. So the patient can go into Toxart, and then it can also displace digoxin from its tissue binding sites, and digoxin in turn can also lead to arrhythmia. So you have to keep these important drug interactions in mind. So quinidine was the prototype drug. Then we have got another drug which is called as Procainamide. Now it possesses all the properties of quinidine, but to a lesser extent. But the most important thing that you have to come across with respect to Procainamide is that it's the way it gets metabolized in the body. Now it gets metabolized by the process of conjugation via acetylation. Now, in the local anesthetics chapter, I have told you that we have got sulfonamides, and we have got other drugs also that are slow and fast metabolizers. Now, the concept of slow and fast metabolizers also comes here in this procainamide. Now, there are two types of individuals basically who metabolize procainamide in a fast way and a slow way. Now, if the patient metabolizes procainamide in a fast way, then there is no harm. But if the patient metabolizes procainamide through an acetyl transferase, that means we'll have a problem. Now, the problem here is that when a patient is a slow acetylator for procainamide, it will cause buildup of procainamide in the body. Now, one important thing with respect to procainamide is that it is a very good hapten. That means it has the property of initiating reactions in
immunity.
the body, right? So when it initiates systemic immune reactions in the body, it is not good for our body. So it can initiate what we call as systemic lupus erythematosus like syndrome. So you'll have butterfly rash and all other things which are related with your SLE like syndrome. So when a patient is a slow acetylator for procainamide, you get this particular adverse effect. Now, there are certain drugs that we'll be studying later on. So just keep it in mind that we have a drug which is called as hydralazine. This is also an antihypertensive, and this also has the potential property of causing SLE-like symptoms. Now, apart from hydralazine, we have a drug which is called isoniazid, which can cause SLE-like symptoms. So procainamide, hydralazine, and isoniazid are your drugs which can cause systemic lupus erythematosus like syndrome. Now, apart from SLE-like symptoms, apart from causing SLE-like symptoms, procainamide can also cause hemotoxicity. That means there will be a decrease in the WBCs. that can result in superadded infections and also cause decrease in the blood platelets. That means it can cause thrombocytopenia also. Then, like any other antiarrhythmic drug of class 1, it also has a potential threat of causing toxicity. So this is procainamide that you have to remember. Now, apart from procainamide, if you just remember this drug, the name of this drug, it will be fine. This is called disopyramide. So we have got 3 drugs for class 1A, which are your quinidine, procainamide,
Procainamide,
and disopyramide.
disopyramide.
So this is with respect to your class 1A drugs. Now moving on to the class 1B drug, sodium channel blocker, as you already have seen in the first bullet point, it blocks the fast sodium channels. Right. Now this class 1B, apart from blocking the fast sodium channel, it exerts its effect basically on the slow sodium window currents. So where do we see the slow sodium window currents? If I draw the normal cardiac action potential of a fast response fiber, the slow sodium window currents basically act on your plateau phase. This is your plateau phase. This is your phase 2. This is where they act. So what they do basically is, apart from blocking the inactivated channels and blocking the slow sodium window channels, what they do is they decrease the action potential duration. Now you might have a doubt that, in the previous class we have learned that all the antiarrhythmics are supposed to increase the action potential duration, thereby increasing the effective refractory period. Now with respect to class 1B drug, I have mentioned here that it is decreasing the action potential duration. So what are we basically doing? So the first thing that you have to talk about is, you have to keep in mind is that we are blocking an inactivated channel. So what are we doing by blocking a channel that is already closed? So to explain this, let me take you back to the previous slide of the sodium ion channels. Now, if you look at this particular slide, the inactive and refractory state, this is the point where your H gate was remaining closed and your M gate was open. Now, after this point, there will come a point of repolarization and the cell will again go back to its resting and ready state. Now, imagine if a patient is in arrhythmia, that means this process is acting very rapidly. All right. So the patient is going from resting to open active stage, from open to inactive, and inactive to repolarization, again resting. So what are we doing for that patient is that we are putting a hold or putting a lock on this inactive state. So when we put a lock on this particular state of an ion channel, we are not allowing it to go further into repolarization. If it doesn't go into repolarization, that means it cannot go back to a resting ready state, and then it cannot go to an open and active state. So what are we doing? We are blocking the ischemic tissue or the unhealthy tissue of the heart muscle. We are locking it in this state itself so that it doesn't go into repolarization and cannot initiate another action potential. If it does, that means the arrhythmia will continue in that person. So keeping arrhythmia in mind, these class 1B drugs will specifically act on that hypoxic or ischemic tissue, and it will lock this ion channel, state of this ion channel. So basically what it's trying to do is, imagine you have a door, all right? You have a door and you have locked it, right? This is your inactive refractory state. Now what this class 1B drugs are doing is, they are putting a lock on this closed door. So when they put a lock on this closed door, that means now nobody can go out. That means it cannot move further into this direction. So when it cannot move into that direction, that means the hypoxic tissue, which was the main cause of causing arrhythmia, is now getting relaxed, and it is not going into the open active state and causing further damage to the heart muscle. So when we go to our actual slide here, what we are seeing is that these class 1B drugs, what they do is they act on the slow sodium window currents, and what they do is they won't do anything much to the phase 0, they won't do anything to the phase 1, but when it comes to the phase 2, they will decrease the action potential duration. Now, for any healthy cell, you will call this as a pro-arrhythmogenic effect. But what you have to think here is that these class 1B drugs, they are very smart drugs. They will not bind to the healthy tissue. They will bind only to the unhealthy, hypoxic, depolarized tissue, ischemic, depolarized tissue, which was the main cause of causing arrhythmias in the body. So what are we basically doing is, we are now causing the unhealthy, hypoxic, ischemic, depolarized tissue to rest a bit longer. So when this tissue rests a bit longer, that means it won't utilize more of oxygen. When it doesn't utilize more of oxygen, that means it is getting into resting state, and it will now again come in synchronous with the healthy tissue and maintain a normal healthy heart rate. So that is what your class 1B drugs are doing. Any doubts here, please ask. So class 1B drugs, basically what they do is they block the inactivated channels of an unhealthy tissue. So when they do that, they decrease the action potential duration. That means they will cause this particular tissue to go into repolarization mode, that is the relaxation mode of a cell, for a while longer. All right, if you see this repolarization uh, point of this particular tissue has increased. That means this particular tissue will have more time to relax. And when it has more time to relax, that means it will utilize less of oxygen. And when it utilizes less of oxygen, that means it won't initiate another action potential. And when it doesn't initiate action potential, that means the arrhythmias will come down. So that is what your class 1B drug does. It will act on the unhealthy tissues. Like I mentioned in the previous slides, that these drugs are very smart. They will bind preferentially to what they want to bind. And class 1B drugs only will like to bind to a depolarized, ischemic, hypoxic, unhealthy tissue. And what it does is it will try to make them rest a bit longer so that the arrhythmias will come down. Now, these drugs basically are used post-MI. That means if you consider this to be a heart, that means what happens is in post-MI, after the myocardial infarction is done, there is a bit of ischemic tissue left. Now, this ischemic tissue has the tendency to initiate arrhythmias in the body. So, we have got unhealthy tissue in blue and we have got healthy tissue in black. So, when you give lidocaine in a patient of post-MI developing arrhythmias, this lidocaine will preferentially go and bind to this ischemic tissue. And when it goes and binds to this ischemic tissue, it will stop the action potentials in this particular tissue. So this is causing action potential at a normal rate, right? And now since it has stopped, it will allow this healthy tissue to get in synchronous with the normal action potentials of normal healthy cells like this. So if you notice, the unhealthy tissue action potential is going at the same rate as that of healthy tissue. This, the red ones are the healthy, the blue ones are the unhealthy. So that is what your lidocaine is doing. It is maintaining synchronous between the healthy and the unhealthy cardiac action potentials. Because we know that the unhealthy tissue is a potent arrhythmic, pro-arrhythmic causative agent. So that is what your class 1B drugs are doing. They will try to make this unhealthy tissue rest a bit longer so that they get in synchronous with the normal action potentials of normal healthy tissues. So lidocaine basically is your drug of choice for class 1B drugs, apart from it being a local anesthetic. And it is used basically in post-MI patients developing arrhythmias. Then we give it basically in open heart surgeries, because when the heart is exposed or when there is surgeries going on, the heart is has a potential threat of causing arrhythmias, and it also serves in digoxin toxicity. Now the adverse effects that is, you have already learned it from your local anesthetics chapter, that it can cause CNS toxicities leading to seizures. And the most fundamental point here is that it is the least cardiotoxic of all the conventional antiarrhythmics. That means it is the least antiarrhythmic drug which is likely to cause arrhythmias in a patient. So that is about lignocaine, and it can only be used IV. So that means only if the patient comes to you in your OPD, you can give this drug, right? So since we have this drawback, we have got two drugs that you have to keep in mind apart from lidocaine, which is your mexiletine and procainamide. These are your oral drugs. So when the patient comes to you, you give IV lignocaine, but when you have to send that patient, you send them with these oral drugs, which are mexiletine and procainamide. So we have got three class 1A drugs that you have studied, which are quinidine, procainamide, and isopyramide. And we have got class 1B drugs, which are again three: lignocaine, mexiletine, and procainamide. So these are the three drugs of class 1A and class 1B that you have to remember. Mexiletine and procainamide are your oral formulations. So this is about class 1B drug of antiarrhythmics. Quickly moving on, the class 1C drugs, basically I would like to call them passport to heaven drugs. The reason these are given this name is because when nothing works, the last resort is your class 1C drugs, because what they do is they can either cure the patient or they can cause a potential flat EKG. Because what they are doing, they are blocking the class, the open active state. They are also blocking the inactive state. They're also blocking the resting state. So if a patient recovers, he recovers. Otherwise, it is passport to heaven drug. So the one drug that we have is flecainide, but it has got a very limited use because it is a potential pro-atherogenic agent leading to sudden death. There's just one drug that you have to remember, and that is your flecainide. So this is all about class 1, which are your voltage gated fast sodium channel blockers.